Good morning, and welcome to Global Neuroscience Institute Grand Rounds. Today, I have a pleasure to introduce Dr. Adam Sarkar. Dr. Sarkar received his undergraduate degree from Brown University and his MD and PhD degrees from the University of Miami School of Medicine. His PhD dissertation had a focus on molecular neuroscience. Then Dr. Sarkar went on to complete neurosurgical residency at Mayo Clinic at Rochester. Currently, Dr. Sarkar serves as a director of stereotactic, functional, and epilepsy surgery and holds a professor rank at Drexel University College of Medicine. As Dr. Sarkar would say this himself, he's a total geek. His name, as well as his initial interest in science and medicine, stem from his father's profession as a biophysicist. Please welcome Dr. Sarkar. Today, he will be talking about functional neurosurgery.
Hey, good morning, Peter. Thank you so much. I will point out for everybody that you're a geek too, but we'll leave it at that. Let me start my screen share and let's go from there. So it's a real pleasure to be here this morning. I know it's unusual times and we're doing this in unusual ways, but I think we're still getting information out there. I am going to talk about functional neurosurgery, in particular, highlight some things about movement disorders, as well as a role that functional neurosurgery has in neuropsychiatric surgery. As Dr. Glebus alluded to, let me see, somehow, I'm part of the Global Neuroscience Institute, which is part of the Drexel Neurosciences institution, where in the Department of Neurosurgery in the College of Medicine, I'm a professor, as well as I have research goals in the Department of Pharmacology and Physiology. My surgeries that I like to do and think that I can help the patients most with are in the realm of what's called functional, which tends to deal with patients that are awake during surgery, patients that need epilepsy surgery, or patients that need some type of movement disorder surgery. Equally, with a wonderful collaboration with ENT colleagues at Drexel, in particular Dr. Bob Sadaloff, we have established the Philadelphia Voice Tremor Center. Now, if somebody were to ask what is functional neurosurgery, the snide answer would sort of be, well, go to a neurosurgery residency, spend 7 years, and then maybe 1 year in fellowship for what's called movement disorder and 1 year in fellowship for epilepsy. And while that would be snide, it would probably at least eke out the pain that it takes to get to this position. But fundamentally, I think that I want to show that even though we're going to spend an hour today talking about a wide range of topics that literally take a lifetime of education, without being disingenuous to the topic, I think you'll get a flavor and a glimpse of what functional neurosurgery is. And in particular, hopefully then, Peter, at some points in time in the future, you'll invite me back for more focused talks, which I would be absolutely delighted to do. This picture is almost 20, well, actually it's more than 20 years old, and it takes me back. And it's funny because it's a sign of the times. I don't think there will be a time anytime soon where 4 people can stand 6 feet apart or less than 6 feet apart for a while without wearing masks. I'd like to start out talking about neurosurgery because I'm really proud to be a neurosurgeon and a neuroscientist. And I think that for medical students that are out there or trainees that are out there listening to this webinar, I'd like to point out that as long as we've been human societies, there has been an interest and a fascination for the brain, whether it was really considered neuroscience or not. But nevertheless, as long as we've been through the Neolithic period, we have been fascinated with things that happen that are direct manifestations from the CNS. For instance, in Eichensheim, over 20 years ago, this paper appeared in Nature that showed that there were, and I hope you can see my cursor, there were these trephines, or these holes that were made in this skull. This is, of course, a type of surgical endeavor. Obviously, it wasn't for the same type of reasons that we have today. Probably more likely it was for magical or spiritual reasons, but nevertheless, this is the first inkling of people looking to the bone, through the bone, to the brain to try to solve problems of their day. Equally, I think it's very, very important to point out the history that we have in neurosurgery, that it goes back and spans almost the moment of the written record for humans. This picture in particular, this picture here is very, it's very heartwarming to me. There are probably very few of you that are around that will be willing to admit their age and say that when they first took neuroscience, there was a textbook called Kendall and Schwartz. And this was embossed on a blue field. It was just that. And the reason for that is that this was the first time there was ever a written description that implied the brain. And that was in this hieroglyphic that was that's often called the Edwin Smith surgical papyrus, for the reason that Edwin Smith purchased it. And the papyrus really was this surgical treatise. And it was a very interesting treatise because this fundamentally had 48 cases that were defined in a way where magic was taken out of the sort of realm of thinking. Maybe the type of, say, care that was being advocated was not necessarily what we would do today, but symptoms, diagnoses, treatments, and outcomes were being depicted. It's incredible when you look at the Edwin Smith papyrus, and I'm not an Egyptologist, but we have our first description of the brain. We have our first description of the membrane covering the brain, which is the dura. We have our first description of the corrugations of the brain, which the Egyptians wrote were like molten copper. And so they had an understanding of the sulcal gyral formations that happen in the brain. And we even had an understanding through the Egyptians that there was actually fluid that was supposed to be in the head. And that's really the first description of cerebrospinal fluid. Now, in addition to the Egyptians, and that papyrus was written, it's believed that papyrus represents knowledge from almost 5,000 years ago, and it believed that it was described by the prominent Egyptian physician Imhotep. He was sort of the all-star of his time, kind of the Anthony Fauci of ancient Egypt. But in addition, from just having that really sort of solid sense of now we're taking mystery and magic out of medicine when we're talking about neuroscience, we move on to another tablet. And again, this is just a short, brief history because I find it fascinating, from Babylonian cuneiform. And you'll see that sort of ghosted out here in the background. And this cuneiform tablet talks about epilepsy, which is actually an incredible thing to think that 4,000 years ago, there were descriptions of epilepsy. And of course, they may not be on par with what we think today, but their descriptions, you can find and tease out various epileptic syndromes. Here you can see that unlike the Egyptians, the Babylonians were invoking demons or departed spirits for what was the etiologic agent for epilepsy. But if you put that aside, you'll see that they're describing this kind of epilepsy where it says that the patient cries that it is he again, and it has possessed him. Well, that's almost like a focal seizure. And here you'll see that it says his life will be spared. But then if you look at another description of epilepsy where it says the demon falls many times upon him, possessing him 2 or 3 times during the day, and that the condition is chronic, the notion is that he will die. And I think that's a very important notion that even through antiquity, we had a direct, keen insight into neuroscience. Now, for many people, you might imagine that neurosurgeons deal with the brain and the spine, and that's absolutely correct. And I think the notion of classic neurosurgery is that oftentimes we're structural surgeons, so to speak. For instance, over here, there's a horrible tumor. It's a glioblastoma. It's in the You can't tell from this scan, but it's in the left parietal region. This required an awake cranial surgery in order to remove it. So there's a problem and we take it out. In other times, as structural surgeons, for instance, here we see the spine. The spine is in the thoracolumbar junction, as we would call it. There is in red here this compression burst fracture that is impinging on the false colored green spinal cord. Again, it's a structural problem, and so we use metal, screws, and rods, as well as cement to distract the problem away and to protect the spine. Again, so these are these notions of structural surgery. There's a problem, it's pushing on something, take it away. There's something that's broken, put it back together. I think that's a very common concept of neurosurgery. But if you're willing to, again, go back and invoke the ancients, in particular the Egyptians understood something clearly in a sophisticated manner about medicine. And not only did they understand something about medicine, they understood that medicine wasn't just all poultices and medications, but that you could use other things. And that other thing I will point out is electricity. And that's really, I would say, where functional neurosurgery makes its distinction from all other surgeries. I would tell you that the currency of the central nervous system is electricity. It's an electrochemical machine. And if you harness just the right amount of electricity and put it in the right spot, you can ameliorate disease. And I think that that was understood by the Egyptians. Over here, you can see, as I've said, that physicians in ancient Egypt used to use jolts from the Nile catfish to reduce pain of arthritis. So you can imagine grabbing a catfish, it stings you, jolts, and then the arthritic pain temporarily is abated. We've become far more sophisticated. No one's walking around with catfish and zapping themselves, but you'll see that our modern take on this is fundamentally have some kind of what we call a pulse generator or a battery that's generating electricity, and having that pulse generator feed up underneath the skin, underneath the scalp, and into the brain, into very, very precise regions in order to deliver a therapeutic type of electricity that can, say, for instance, stop epilepsy, or that can stop the tremors of Parkinson's disease, or, as I'll talk about later, have some interesting roles in some neuropsychiatric issues. I think another thing about functional neurosurgery is that, for instance, if I have a tumor in somebody's head, it doesn't take a team of experts to really tell me that I better get to the OR to take the tumor out. But in functional neurosurgery in particular, we're dealing with topics like movement disorders, or we're dealing with topics such as epilepsy. And it really does take a team of people to come together in order to help inform me as to how this problem is now intractable, no longer medically, pharmacologically amenable, and that they need surgery. So in particular, I have a fantastic team of colleagues such as Dr. Farmer, Dr. Lester, Dr. Gallo, Dr. Goffman, Dr. Maxwell, that helped me outside of the OR. And then my partner in crime inside the OR, mostly for these awake cases, is Dr. Kate Vexler. Another hallmark of functional neurosurgery, in distinction to, say, all other forms of neurosurgery, is this notion called stereotaxis. And stereotaxis, it's a Greek term, and what it fundamentally means is that you have a fixed reference frame. And that doesn't matter if you're measuring something like at this ancient WHO site in Jaipur, India, which is called Jantar, Mantar. And it's a site where they have these fixed devices, all of them throughout this property, that are being used to track celestial objects. And so stereotaxy is a way of predicting position and location through other fixed reference sources. And fundamentally, what we've done in neurosurgery over time is we've taken that notion of looking at the stars with stereotactic positioning and turned it internally to look at the brain with stereotactic positioning. This is a little bit of a busy slide, but part of this slide is actually a tribute to Philadelphia. Philadelphia is really a town that harbors and fosters medical innovation. These were two surgeons at Temple, Spiegel and Weiss's, and they are creating this contraption. The patient is here. You can see his nose is right here. He has this incredible plaster of Paris head mold, and he has this chamber here that will be closed around him that will shield off electrical signals. And this was the very, very early forms and attempts of what's called stereotactic surgery or functional surgery with high precision localization. Now, over time, this, let's call it a torture device, morphed into this more benign looking device, which was made by the Swedish neurosurgeon Lars Leksell. And this is called aptly a Leksell frame. This frame has points where they actually engage the skull. And you can almost get a sense that this is a box or a volume. And so if you put a patient into this so-called external frame and you get a MRI scan or a CAT scan of them, every point in this three-dimensional space can now be referred or has a reference to this frame. It's sort of like a three-dimensional game of Battleship. You say B27, and that is, for instance, the subthalamic nucleus. I'm being a little bit facetious here, but that's how these frames work. We've gone even further, and as a matter of fact, I prefer using, of course, not this and not even this, but something that we call frameless stereotaxy. The frameless stereotaxy means that the patients aren't linked into this frame, strapped into the bed where they can't move their heads, but we've taken sort of technology that's very much akin to global positioning technology, GPS, and we use these screws that actually go into the bone in, say, 4 spots, because if you have a three-dimensional object and you use at least 3 or maybe 4, say, satellites, you're able to then geoposition or neuronavigate to any other site through triangulation. And we can make frames that are very specific, they're customized, they're low stress on the patient, and they allow us to pinpoint targets deep within the brain with less than a millimeter of accuracy, which is really spectacular and fantastic and important for safety. I was mentioning, and now we're going to get into the clinical aspects of, say, movement disorder. I was talking about the fact that as neurosurgeons, we're often structural surgeons. If there's a tumor, you take it out. If there's a fracture, you repair the fracture. My vascular colleagues, when they deal with blood vessels that rupture, they occlude the blood vessel rupture. So we are very, very, very much in a mechanical field, even though we deal with the brain and the nervous system. But here's where I think functional neurosurgery shows that it's just absolutely incredible in what it can do. So most medical students know Parkinson's disease. We've all heard about it. It's one of the things that whenever we say we're going to try to help people with stem cell therapies, we talk about Alzheimer's and Parkinson's disease. So it has an ingrained sense of understanding in both the medical community and the lay public. James Parkinson, what many of you may not understand or realize or appreciate, is over 200 years ago, he made comments and observations while he was watching people walk. So he actually never really examined these patients, and they were, and he called them the shaking palsy. He didn't understand that there was this rigidity to them because he actually wasn't examining them. But he noticed these involuntary tremulous motions, and he noticed that people had a very particular stooped attitude, and that he felt that their senses were not being affected. Although these days, I think that we will appreciate, and Dr. Glebus would know this better than anyone, that there are some neurocognitive effects from Parkinson's disease. But let's keep that aside and let's focus more on, say, this picture here. This is an area of the brain, a deep area of the brain called the substantia nigra. It gets that name nigra from black or dark from these pigmented neurons in the substantia nigra, which contain the substance dopamine. In a patient that has Parkinson's, there's a loss of dopaminergic neurons. In normal patients, they're replete with dopaminergic neurons. So if you think about it, what we're doing here, or trying to do here, is replace the loss of these dopaminergic neurons. Well, one way to do that is to say, well, geez, why don't we add more dopaminergic neurons? Why don't we find a source of dopamine and let's put them here, whether it's a source that's from an adult, whether it's a source from a stem cell, let's put them in here. And indeed, that's been tried, but that doesn't work. And that's probably in part because the brain is far more complex than we can ever hope to really truly ascertain. So the incredible thing here is that instead of finding more dopaminergic neurons, we use a little bit of electricity in this subthalamic nucleus area, or in this substantia nigral area, to counterbalance the loss. So here we're able to actually take care of something that's lost, not something that we're going to add to the structure again, but something that is lost. Use the currency of the brain, which is electricity, and return function. To do this really takes a team. I talked about the team that we have outside of the operating room, including folks like Dr. Farmer and Dr. Gallo and Dr. Lester and Dr. Maxwell and Dr. Goffman. But then there's a team of folks inside the operating room. And these are very busy, crowded places because we're doing a lot of different things. Patients are awake. These are awake surgeries, believe it or not, as crazy as that might sound. There's a lot of finessed neurophysiologic monitoring with very fine instruments and devices. And in neurosurgery, we're used to very fine, nuanced, delicate instruments, but these are way more than that, where we're using electrodes that are literally the size of a hair in order to measure neuronal activity. In addition, I would point out that in order for us to help our Parkinson's patients, we really have to know where to put the electricity. It's no different than, say, real estate. It's location, location, location. And this kind of delivery of electricity into a very precise part of the brain is called deep brain stimulation. It's a technique that we've had for over 20 years. And as a matter of fact, when I first started my residency at the Mayo Clinic, we first started doing these cases because, as you can see in this slide, the FDA approved the use of deep brain stimulation in 1997. I started residency in 98. And at the Mayo Clinic, that's when we were doing these cases. So I've got a very long history of doing this. Parkinson's disease then became FDA approved 5 years later. Another type of movement disorder called dystonia, which is an abnormal contracture of musculature, was then also approved. Something that might not seem obvious because it's not movement disorder related, but obsessive compulsive disease has a human device exemption for use, and then epilepsy conditions, medically refractory non-focal epilepsy, and I'll get into that a little bit later, can also be treated with deep brain stimulation. Again, the notion is a little electricity in the right spot using the currency of the brain can solve brain problems. And those right spots can be places such as what are called the thalamus, the subthalamic nucleus, or the globus pallidus interna. I'd like to point out this. Down here, I say that in the last 23 years, there have been about 155 1,000 patients implanted worldwide. And that actually seems like a pretty robust number. When you break it down to thinking that that's the whole world, and that's over 23 years. So in the whole world, on average, any 1 year, there are fewer than 7,000 implants, which is actually astounding. Because when I showed you that picture of the spinal instrumentation, and there are some screws that you may or may not have been able to appreciate, in any 1 year, not 20 years, but in any 1 year in the United States, there are 2 million pedicle screws that are placed. So you can get the sense that this kind of therapy is a therapy that's done, but certainly at certain centers. And we're very, very fortunate at Global Neuroscience to be one of those centers. Another thing I'll point out, this is what's called a coronal slice, meaning the slice is this way from ear to ear. So one ear would be here, one ear would be here, and this is a slice that's going from ear to ear. The surface of the brain is out here, those corrugations, the cortex, and all the structures or most of the structures, the classic structures for helping with functional neurosurgery, in particular DBS for movement disorders, are located literally in the center of the brain. One of the structures, for instance, the subthalamic nucleus, is only 6 millimeters big in its length. That means if you're not used to thinking about millimeters, it's 1/4 of an inch. And you're coming from way out here down through critical pathways to try to hit a target that's 1/4 of an inch big. That really takes an immense amount of precision and a certain, or for sure, a certain amount of measuring twice and only cutting once. So how do we do that? In order to do that, we're very fortunate that we have high resolution imaging, in particular MRI scans. And MRI scans are the lifeblood of any kind of functional neurosurgeon. In an MRI scan, there are structures that we know that have physical representations to other structures, much like on a map, you know that Georgia is above Florida. Well, in this brain map, MRI, we know that this structure here called the red nucleus is just in front of the substantia nigra, which means it's right next to something called the subthalamic nucleus, which is our target in Parkinson's disease. So we have a certain sense and a nuance of once we know where images or structures are in the brain, that we can then target those structures. That's called direct targeting in functional neurosurgery. And then what do we do when we're there? Well, we do a lot of things. One, we measure a bunch to make sure that we're in the right spot. And then we ultimately implant these electrodes. And these electrodes are fairly typical of any kind of deep brain stimulation electrode. And that is that they have multiple contacts where they can deliver a certain amount of energy or electricity or current over a particular prescribed period of time interval with a particular pulse wave or curve. The brain, again, going to an analogy of a map, is just like different parts of the world. And in this map here, the different colors could represent, well, they do represent different brain nuclei, which are, in an analogy to a map of the world, different countries. And in different countries, you have different languages. So for instance, if you're starting out in Lisbon and you want to end up in the coast of Italy, in Ventimiglia, you're going to have to make sure that you travel through Portugal, so you're hearing Portuguese, to Spanish, through Spain, so you're hearing Spanish, and then through France, so you're hearing French. If you start hearing Hindi, then you're probably lost. And that's another sort of analysis or analogy that I would have here. In the brain, in order to get to this structure called the subthalamic nucleus, we have a pathway that is not only confirmed radiographically, but also electrophysiologically, so we can hear the brain. And if this works, I will play some sound. So for instance, this is a part of the brain where you can hear this statically bursting kind of sound, and not unsurprisingly, these are called burster cells. There's another area as we go on our path, again, this is like we're taking a very, very stylized path, we can hear these cells that don't burst as frequently, and so they're called pausing cells. Finally, and I'll skip one of these just in the interest of time, we get to a spot where you can almost hear this tremulousness to the frequency of the neuronal signal. And those are our tremor cells. And when we know from our navigation and from our electrophysiology that we're in the right spot, we are absolutely certain that we can help our patients. Now, how do you convince a patient to submit themselves to all this? Because keep in mind, these surgeries are awake surgeries. Well, a while back, I developed this activity, and I don't know if it's going to work. If it doesn't, we won't do it. But if it does, it'll be somewhat fun. This is an educational tool for deep brain stimulation surgery. And it's actually a way that we get our patients to understand what they can expect from surgery and how we can help them and somehow demystify what's going to happen.
Five-step process of helping a patient with movement disorders.
I'll let this run for a little bit.
Our patient is a 59-year-old woman named Ellen, who is 5 feet 8 inches tall, weighs 120 pounds, and has suffered from Parkinson's disease for the last 20 years. Ellen is an attorney and cannot leave court to take pills every 2 hours, which is
you can see that we've got a way of going through all the steps of DBS surgery, and I'm just jumping ahead to surgery and how it's beginning. And this, again, is a way to demystify
and make
surgery
an incision where we marked earlier
for our patients. And so we can get them to almost do their own virtual surgeries.
Wow, your hands are as steady as a giant oak. Now use the Bovie.
And then there are other things that we can do, again, so people understand they're awake. And when they hear us say things, they're not so surprised because they've encountered it in this kind of little cartoon. And then finally, we can end up with
we need to set the two stimulation
the neurology
component
component,
control your tremors.
where we're talking about how we're going to control the
I'm going to
tremors.
set the stimulation
So
at different levels.
that's just a kind of cute little way of how we help our patients
tests and motion tests as
desensitize and have a better understanding of what's going on with their surgery. And it's a lot of fun to have them go through it because they find it very reassuring. Let's see. Surgery itself actually is a little bit more nuanced. And this is us in the operating room. And you can see over here that there are, one, a lot of people, and two, there's a fellow in there. He's not holding hands just because he wants to give comfort and support, which he actually is. He's holding hands because our patient has a really horrible tremor, and you'll see that. He's left-handed, and that's his tremor. He can't write. Obviously, he can't feed himself with that dominant hand. He can't even control how he gets dressed. We're working in the right brain, and then we're going to affect symptoms on the left side of the body, and you'll see that momentarily when we activate electricity.
Sweet.
And I think the patient says it all.
Sweet spot, baby.
So, and then writing, when you go from, somehow I've lost my cursor. Don't know why. Hold on a second. Let's see if I can go back to this. Writing with electrical stimulation on and remember, they're in a very awkward position, but that's very, very legible writing, whereas preoperatively, without any stimulation, their writing is fairly illegible. What's the final sort of outcome of this? You get 2 electrodes in your head. There's one here, there's one here, and some form of battery or pulse generator, hearkening back to the Egyptians, this is the catfish. It might seem like an incredibly dramatic thing, but our patients are so happy to receive this therapy and have the option for this therapy that they're seeking us to have it. And it's a really, really heartwarming sort of episode of our ability to impact their lives. Now, the other thing that we do in functional neurosurgery, and there are lots of different aspects of functional neurosurgery, some actually have to do with the spine, but I won't get into that today. One of the other things that we treat in functional neurosurgery are seizures. And there's this group called the International League Against Epilepsy, and I always sort of like think of them as the as like kind of some kind of superhero group. But nevertheless, what they do and their focus is to take terms and also take old terms that are muddled and confused, like those Babylonian terms, and then create them into a comprehensive didactic sort of way of dealing and discussing about what epileptic syndromes are. I won't get into anything like what is a generalized absence seizure or what is a focal sensory aware or impaired awareness type of seizure, but just understand that epilepsy is another form of electrical activity in the brain that now is synchronized, but in a manner that is not beneficial. Epilepsy surgery over time has evolved, and certainly this is a case that I did several years ago where we literally exposed one whole side of a patient's head. This would be what's called the frontal lobe. This is the very anterior tip of the temporal lobe. This is what we call the floor of the temporal lobe. And then this is going back to the occipital and parietal areas. And this patient had some type of epileptic syndrome that we weren't fully aware of. They had to get a wide implantation. These are what the grids look like. There are grids that can go in onto the brain to really directly closely map where aberrant electrical signals are coming from. And you can imagine that there is a degree of what we would call morbidity to this. I think one of the hallmarks of functional neurosurgery is to get progressively more minimal. And these days we can do this kind of wide implantation strategies. And this is one that we just did maybe a couple months ago, just recently, through stereotactic functional neurosurgery, where we place electrodes throughout the brain and are able to determine where aberrancies are. That still doesn't mean that there are going to be times where we're going to have to openly map the brain and find out where a problem is. For instance, in this patient, we found out that there was a problem in the left side of the brain that was controlling their dominant right hand, but it was an epileptic problem. So taking out that region of the brain would have solved their seizure, but it would have left them paralyzed in their dominant right hand. So there are ways of actually having literally like a artificial intelligence machine placed into a patient. This is a computer processing chip and a battery. It senses electrical activity, and through artificial intelligence, really making sort of like a cyborg, it's able to dispense or quell seizure activity, which is absolutely fascinating and remarkable and worth the topic all on its own. Here's another situation with one of those kind of AI or NeuroPace implants. We've placed these electrodes into our patient. They have very minimal in the way of discomfort. I'm not going to pretend that they're painless and that they don't just tickle, but they are really, really super well tolerated. Here's one of our heroes. His name is Azariah. Our functional patients really are our heroes because we put them through so many rigors to ask them to how to help themselves. You can see that there are abnormal squiggles here on the EEG. I'm sure any epileptologist would cringe at that description, but nevertheless, that's what's happening here in this posterior aspect of Azariah's brain. And that was an area that we weren't going to be able to resect without leaving him with a very significant language defect. So in fact, we made him yet another human cyborg with this NeuroPace or brain pacemaker, implanting it, again, not removing tissue, but just using the currency of the brain, electricity, to solve problems in the brain. And what that basically looks like is this. Now, Azariah walks around with this functional system of EEG that is always constantly measuring him and dispensing electricity when it finds seizures. And he's been seizure-free, and I have to say, that's an incredibly wonderful outcome in a kid who's 11 years old and can now get his life back, go to school, study, and become a functional member of society, as opposed to having seizures that would probably preclude many of those things. I know the hour is getting a little bit on the late side, and I did want to touch on this because I think this is really interesting. So if you say, where is functional neurosurgery today and what can we do with it? Well, we understand that there's seizures, but we've known about seizures historically, as I showed you, through Babylonian times. We know about movement disorders, and we've been treating those for decades. But what about neuropsychiatry? And I say this with a little bit of trepidation because I know neurosurgery has somewhat of a black eye from the notion of what is called psychosurgery. But I promise that if it's done correctly, it can also be something that I think is the next wave of where we will be going. Many medical students may recognize this name, Phineas Gage. And the reason why Phineas Gage has his own sort of stamp in the medical lexicon is because he was a railroad worker almost 150 years ago when an explosion happened and a pole, an iron pole that was pointed, entered right under his left cheek, just behind the orbit and into this anterior left frontal cortex. You can see the descriptions here are the orbital frontal cortex, the mesofrontal cortex, and the cingulate gyrus. But you don't have to really get too hung up on that, aside to know that there was a dramatic injury that happened here in this left frontal region. Phineas amazingly survived, and I won't get into the details of this, but what happened was that his mind was radically changed, so decidedly that his friends and acquaintances said he was no longer Gage. And this was an indication that somehow things could be done in an ablative manner that would change people's personalities. This slide is a really important slide and a little bit controversial. All of my vascular colleagues will probably recognize Egas Moniz. This fellow was really a man of all seasons. Egas Moniz was a neurologist. He was the chair at the University of Lisbon. He was a diplomat as well, and was one of the signatories for Portugal's signing on the Treaty of Versailles. But Moniz was also the developer of cerebral angiography. And in addition to that, Moniz latched on to the notion through animal experiments, mostly dogs, but some primate experiments, that there was a way of calming people or changing their neuropsychiatric character through surgery. Moniz was a neurologist, and so he had to recruit a friend, Almeida Lima, who was a neurosurgeon, to do surgeries that he felt should be in the frontal lobe, to disconnect this lobe and to calm individuals. He collected 20 patients in less than 2 years and created this publication in 1937. Interestingly enough, even though Moniz did this with Almeida Lima, it seems like Moniz is the only author on this American Journal of Psychiatry paper. And I'll point out what he did. It was mostly psychiatric patients that were either suffering from depression or schizophrenia. And here he says that following this exposition, I do not wish to make any comment since the facts speak for themselves, which they actually don't. These were hospital patients who were well studied and well followed, which they actually weren't. The recoveries have been maintained, which is actually not true. And he goes on to say, I cannot believe that the recoveries can be explained upon simple coincidence, which it probably was. Prefrontal leucotomy, we call it lobotomy now, but he called it a prefrontal leucotomy, is a simple operation, always safe, which may prove to be an effective surgical treatment in certain cases of mental disorder. I think that statement can be taken with an enormous grain of salt. Nevertheless, that statement fired up this fellow, Walter Freeman. Again, another neurologist who was quite taken by this notion of what's called, or ultimately became called, psychosurgery. Freeman was a neurologist. He was a chief at George Washington University, And he performed over 3,500 lobotomies. Initially, he worked with the neurosurgeon partner, James Watts, but I think even Watts understood that Freeman was a little bit on the fringe, and Freeman took this to a point which was almost a point of lunacy. Freeman created a technique that was called the ice pick lobotomy, where ultimately you would just go through the orbital roof and then sweep back and forth and basically create a mess. And he said that these surgeries were helpful. One of Freeman's most famous patients was this young lady, Rose Kennedy. So you can see that it wasn't people that weren't for lack of resources or access to medicine, but this was almost a fashionable thing to do to try to help cure mental illness in a way that should probably have never, ever happened. When it was said about Rose's work that the lobotomy helped cure her of all her aggressive impulses, that might be true. But the problem was that Rose Kennedy was then rendered off to a convalescent care in a convent and effectively was unable to ever take care of herself. It's actually her sister, Eunice Shriver, who then created the Special Olympics in honor of Rose because of her affliction. Here are some images as to why. These are different patients, 3 different patients treated for schizophrenia, and these MRIs are almost 40 years after they had their lobotomies or leucotomies. And you can see here there's sort of this lesion up in the frontal lobe, here there's a smaller lesion, and here there's almost no lesion. And I think probably one of the problems that the early psychosurgeons encountered was the heterogeneity of whatever it was that they were doing. I think that it's very telling that Freeman and Watts actually acknowledged, in contrast to Moniz, that there were adverse effects of the surgery, and that I think this is pretty important. Every patient probably loses something by this operation, some spontaneity, some sparkle, some flavor, personality. And I think that was at least one part of their credible statements that have to be overlaid on most of their other incredible statements. Psychosurgery really has a place in, I think, popular consciousness because of not surgeons or medical professions saying, hey, hold on here, but it was really through lay publications and press, like One Flew Over the Cuckoo's Nest. And if you ever read Ken Casey's book, or if you see the movie with Jack Nicholson, you'll have a sense of what was at stake here. Now, back before there was really any kind of real formal deep brain stimulation, the World Health Organization defined psychosurgery as selective surgical removal or destruction of nerve pathways to influence behavior. These days, as neurosurgeons, we're using non-ablative, neurorestorative approaches like our DBS to deliver electricity to try to solve problems that would otherwise seemingly be unsolvable. For instance, I told you that the FDA has approved DBS surgery for essential tremor, Parkinson's disease, dystonia, even epilepsy. Well, there are also approvals for something such as Tourette's syndrome, which might seem unusual, but it is somewhat of a motor tic disorder. But then even more importantly, because I think this is where the future of functional neurosurgery is going, it's being investigated for its treatment or use in depression, epilepsy, other forms of epilepsy, cluster headache, eating disorders, which include both anorexia and obesity, as well as in Alzheimer's disease, pain, addiction, and even minimal conscious state. So how do we move to this point? Well, one thing for sure is if you're going to understand how to do that, you have to go to where that's being done. Believe it or not, in China, in particular at this hospital, this is called Rujing Hospital, this is in Shanghai, they do about 400 cases a year of DBS. Most of it is not for movement disorder, Most of it is for neuropsychiatric therapies. And I'm not going to comment as to what I feel is right or wrong here, but I wanted to go and see what's happening to better inform myself for how we might be able to help patients here. And I think the real premise here, and I'll pretty much tie up, is that in the 21st century, neurorestorative surgery or functional surgery has to follow strict ethical guidelines. We are fundamentally tied in to technology and innovation. We're going to have to understand what are electrical signals and characteristics of parts of the brain that are diseased, and how can we know those electrical signals or characteristics when we've improved them. And I think because I've shown you that we're putting things into the brain, progressive minimalism is going to be important for these therapies to get and gain wide acceptance. So Peter, with that, I think the brain in the bottle for me usually means my day is over. And if you want to jump back in and let me know if I still am the geek that you thought I was.
Oh, you are. You are. No, I thought that was a great talk. And I think everybody, who joined in, starting from medical students, to the attendings who are practicing for a long time, really, learned something from this talk. So thank you very much. We do have several questions for you. And one question is, the very initial step of target selection. Okay, and how did it even, because I do assume that we cannot really totally rely on an animal model here.
No.
And, who was the brave one, to just say, okay, let's poke the needle into this nucleus and see whether it's going to, stop the symptom or add this symptom or whatever. So can you comment on that a little bit?
So believe it or not, the credit here really goes back to vascular surgeons. Vascular surgeons were doing, and there's a guy named Cooper, who actually found that when he occluded or tried to take care of an aneurysm in the anterior circulation in a patient that had Parkinson's disease, that there was an unintended occlusion, but that their Parkinson's got better. And so that notion of ablating then became sort of, came to fruition. The notion of how we went from ablation to stimulation is a really interesting story. It probably would take too long, but it was also yet another accident, like many things in medicine are, but it happened with the right practitioner who understood the benefit of that sort of misstep and used it as a feature.
Another question. So applications for deep brain stimulation are vast. How would you determine if it works in conditions where there are no motor symptoms like Alzheimer's disease?
Well, you see, Peter, that's the thing. Movement disorders, in a way, and I, with all deference to Dr. Farmer, in a way, they're easier because there is that external manifestation. You can tell, oh, wow, your tremor stopped, or you're no longer rigid. It's a real challenge to understand. Well, we can put, say, like, let's make up something like we can put something in the nucleus basalis of Minards. I can get there safely. But the question is, what should my stimulation parameters be? For how long? And I think that's where we have to use technological innovation and understand what are signals that come from normal and abnormal brains. And that's where we're going into something called a closed loop system where much like in epilepsy, we'll read certain signals that say, oh, there's a seizure that's going to happen. Maybe we'll understand that there's a particular frequency, a beta band or a gamma band or a theta band that's very unique in Alzheimer's, and then target that area and see if we can disrupt that. So that's why we don't use it ad lib in all these areas. I mean, let's be honest, for addiction, the Chinese are using this a lot. In India, they're using it a lot. It's not really clear what's the right target and what's the right setting or electricity.
Okay. Another question. So when it comes to these surgeries, they're fairly safe. We can say that. I guess every surgery has inherent risk to it, but they're fairly safe. But I think it's, when talking to patients about the surgery, it's not the benefit, or they know the benefit of it, but they're mostly what they're concerned are the risks. And
Yeah.
what is the prevalence of risks? You know, in these
So it's surgery.
Yeah.
It's surgery. So you're right. There's always a risk. There's risk to anesthesia. There's risk to infection. There's risk to just the hardware not functioning because it's a mechanical device. So there are risks, but these risks are really minor risks. And I would say that the risks are probably less than having a simple lumbar microdisc being removed. I think the thing that really gets people are the notion of, oh my gosh, you're having surgery for Parkinson's disease when you could take a medication, or you're having surgery for epilepsy when you could take a medication. And I think that's where our patients become their own advocates, because they find other folks that have had this surgery and it's changed their quality of life. And so the risks, I think, are inherent. Patients have certain risks in their heads when they think about brain surgery. But for instance, at EdHead's tutorial, we try to mitigate that and try to get people to realize that it's not a game, but we'll get you through it, and we promise that you'll be happy.
Another question, and that is more general question. How does electricity work in the brain?
So electricity is the actual currency of the brain. Going back to medical school, there's something called the Nernst potential and an action potential. And that's neurons actually, and all our cells sit in a state of electrical activity. And when there's a depolarization, there's the flow of current. And then we go to another site where there's what's called a synapse. And that's this electrochemical transmission or signal. And that's how the brain actually works. And that's how signals are sent.
Okay. Now, we still have several minutes. So what are the long-term side effects to brain stimulation, and does the effect wear off?
So that's a very, very reasonable question. And so the long-term side effects, we don't know that there are any long-term side effects of deep brain stimulation. The fact that we're not solving Parkinson's, we're not solving or curing, say, dystonia, or we're not solving essential tremor is the problem. So the disease still progresses, but the nice thing about having the neuromodulation is just that. Don't think of it as a light switch that turns on or off somebody's symptoms. Think of it more like a rheostat or something like a thermostat in your home, where you're modulating up or you're dialing up to deal with the fact that this is a progressive disease.
Okay. Dr. Sarkar, really thank you very much. It was a great talk, and I'm sure everybody enjoyed it.
Oh, great.
I would like to thank everybody for joining us. We will resume our grand rounds in 2021. I would like to wish everybody happy holidays and see you next time.
Thank you, Peter.
Have a good one.